from the US. Although these two buildings may look very different, they have a lot of things in common. They both stand for, they're both cutting edge innovations. This building may look pretty old and decrepit, but this was the first DGH in the UK to get a CT scanner. This was when the CT scanners were only head scanners, and were built by EMI, the music company. This was the third hospital in the world to get a CT scanner and the first DGH in the UK to get a CT scanner. So lots in common. So let's move on. First of all, I have no disclosures. There are no conflicts that I want to declare or I need to declare. So this is what we'll probably be going through over the next 35 to 40 minutes. I'm going to briefly talk about the epidemiology of headaches, look at a few definitions, talk about some indications for imaging, the selection of an appropriate imaging modality. We'll go through some cases, and we'll finally end up with the question and answer session at the end. So epidemiology of headaches is a little bit difficult because it's such a common neurological symptom. WHO estimates that everybody in the world will have experienced a headache at least once in their lifetime. Half to 3/4 of all adults between 18 and 65 have had a significant episode in the past year. And up to 4% have a headache on most days of the month. And it's one of the biggest causes of loss of quality and loss of disability in the Western world. Most of this data is from this Atlas of Headaches that the WHO published in 2011. This was a questionnaire-based study in which Pakistan also participated. And more or less the demographics are similar the world over. With it being so common, most people don't actually seek out professional help. Most of the people just tend to treat themselves. So only about 1 in 10 of people who have headaches actually get professionally diagnosed. Having said that, it accounts for about 10% of all primary care consultations and up to 1/3 of all neurology referrals in the world. And about 1 in 5 of general medical admissions has headache as one of the presenting complaints recorded when the patients are admitted to general medical inpatients. So bottom line is headaches are very, very common, which brings us to what the kind of headaches they are. And the IHS classification describes headaches into 2 broad categories: the primary headaches, which are without an underlying disorder. The tension type headaches are the most common, migraine clusters, and the headaches which are secondary to an underlying disorder, which may either be just overuse of medication or inflammatory conditions, tumors, infections, etc. They are all secondary headaches. So most of the time, the primary headaches, if you can come to a conclusion that the headache is primary, does not need to be imaged. The headaches that do need to be imaged are the ones which you think may be secondary. And to help you figure out which ones there are, this one, you need to do a full physical history and physical, and it's the history really that establishes most of the issues with when you're trying to diagnose a primary one. This is your guys' area of expertise. I'm not going to talk about that. And you also need a full neuro exam. What you do want to do is to look out for the so-called red flags. This is from the Cleveland Clinic's own pathway for dealing with headaches in the ED. The SNOOP mnemonic is very widely used. some people use Snoop plus 2, some people use Snoop to the power 3. Essentially, what this is just a way of trying to remember what are the features that should prompt you to have another look at that patient and decide whether you want to do something else rather than just label it as a primary headache. Fevers, chills, meningitis, etc., papilledema, pattern of change, especially if they have neurological symptoms or abnormal signs. These are all red flags that should prompt you to look at the patient again and try and figure out if there is something more serious than, when I say just a migraine, speaking from experience, migraines are not just another migraine. They may be the most debilitating thing to have happened to you. So if you have one of those red flags, so the different red flags would mean different things, and different red flags would have different connotations on what you are likely to find. For example, if you have focal neurological signs, which are not like the typical aura that the patient may have prior to a migraine attack, you're really thinking about a very serious problem, which may be an intracranial mass lesions or a vascular disorder. And you may not necessarily want to do just imaging, you may want to do other things. Similarly, if you have headaches that are triggered by cough or exertion, or if they have mental status changes with it, you're going to have different things. Just to complete the list, remember that if they have an underlying disorder, for example, if they have a known neoplasm, the likelihood of there being a serious intracranial issue as a cause of the headache, especially if the headache is of recent onset, is very much there. So once you've decided, once you've gone through the history examination, you've decided that you want to image this patient. You've done your blood test or whatever. Your choices are essentially an MRI or a CT scan. I'm not really going to talk about polymyalgia rheumatica or giant cell arthritis, although that is an important one. Radiology is usually used to exclude other causes. There is some data out there that temporal artery ultrasound may be helpful. There is increasing data out there that shows vessel wall imaging may have a role. But again, that's a very small area. And just to keep this discussion focused, I'm not really going to talk about ultrasound. One thing I would say to you is, please do not request plain films. Until recently, I was still seeing requests for examinations such as this. So this is obviously a patient with a probable pituitary adenoma, which has got a enlarged sella and destruction of the posterior clinoids. But this really doesn't help you in any way at all. If you see it, you will need to go in and do an additional exam. If you don't see it, it does not exclude it. And this is just radiating patients for no reason. The same is true for sinus views. Again, I would recommend that either you make a clinical diagnosis, or if you think that they're going to need sinus surgery or something more, then what they really need is a CT scan, and the plain film really does not help anybody, doesn't even help the patient. So if you decide that they're going to need imaging, your two choices are CT or MR. They are fundamentally different. CT uses ionizing radiation, and therefore its use in young people and women of childbearing age should be considered very seriously before you embark on it. MR is much safer if you don't have an implant, or if you don't have an intracranial or a metallic foreign body. But MR has absolute contraindications. CT has no absolute contraindications. And if you have patients who are acutely unwell, you may not be able to monitor those patients in MR, and therefore you might want to do a CT scan. By and large, for most acute conditions, you would do a CT. For most chronic conditions, you would do an MR, but that's a rule of the thumb. You may want to do different things depending on what you're actually trying to figure out. One thing to remember is both intravenous iodinated contrast and intravenous gadolinium are nephrotoxic. Gadolinium is not safe in renal failure. There is a lot of literature out there about appropriateness, and one of the most widely used appropriateness criteria are by the American College of Radiology. A lot of the times what the appropriateness criteria deals with is cost effectiveness. Cost effectiveness only works if you have a third-party payer. If the patient is paying out of his pocket, the cost effectiveness goes out of the window. Having said that, it is always useful to refer to an appropriateness table if you are going to if you're going to refer to anything as a guide to what you should be doing. So, for example, if you have a headache in pregnancy, you might want to do an MRI without contrast, looking for things like PRESS or CVST or whatever. And if you have somebody who's suspected of having meningitis or a subarachnoid hemorrhage, you might want to do a CT scan. And so therefore, it's always useful to have at least gone through a list of appropriateness and familiarized yourself with what is available, what would work in what, if depending on what you are suspecting in the first place. Remember that no matter what you do, the yield of imaging in somebody whose primary presentation is headache is very, very low. So this is if you are using CT scans in unselected patients. So this is not patients who are being selected with the so-called red flags. These are patients who were just referred for CT scans. And this data is actually a little bit old, but is being reproduced multiple times. Usually it ranges between 1.5 and 2%, typically below 1.5 for CT scan, and typically below 1.2 for MRIs. You may find other abnormalities, but they are probably, they're not relevant to the diagnosis of the headache that you were doing the MR for in any case. So findings relevant to headache are usually very small. Remember that even if you have one of the red flags, your likelihood of picking somebody with a detectable abnormality, even if the red flag is there, is, if you take all the red flags as a whole, is less than 10%. If you take, for example, somebody with papilledema or focal neurological signs, your yield goes up to about 25 to 30%, but up to half of people who have papilledema on fundoscopy will have a normal or a non-contributory brain image. So, so to keep that in mind, yield of imaging is usually very small. You have to put that in the context of whatever else you are doing. With that, we'll just move on to case review. And because I think this would be able to bring out most of the points that go in the decision making as we do this. So what I'm going to do really is, ideally I do this with a audience response system in the hall, and people either use their smartphones or response device to give their answers. But what we will do is I will put the clinical info. People just think about what they are going. I'm going to go through the images, and in the end, I'm going to say what the diagnosis is, and hopefully this would help people figure out where we are heading. So firstly, a 51-year-old lady who has no known comorbids. no prior headache disorder, sudden onset of severe headache, worst in her life, has never had one of these before. NED has frank neck stiffness. This is her CT scan, and everybody would be able to pick this out, that there is high attenuation material in the basal cisterns, both Sylvian fissures, interhemispheric fissure. She has some calcification of the anterior forks, which is neither here nor there. She has blood extending into her ventricles. You can see fluid levels in her ventricles. She has high attenuation material in the fourth ventricle. So all of this is subarachnoid hemorrhage. And once it is this obvious, it is not really difficult to pick out. And sometimes you are even, so this is an acute subarachnoid hemorrhage. And sometimes you are lucky enough to find the cause of it on your non-contrast CT. And you can see that there is a big basilar tip aneurysm around which this blood is loculating. Because the blood is flowing, it is of a lower density, and you can see this large aneurysm. But once they are this subtle, the diagnosis becomes a little bit more challenging. So you can see here, there is a little bit of high attenuation in the interpeduncular cistern. There is a little bit of high attenuation in the ventricles. The ventricles are starting to dilate. So this, and there is a little bit of high attenuation in both Sylvian fissures, in the right Sylvian fissure and in the left Sylvian fissure and in the right Sylvian fissure. So this is another patient with a subarachnoid hemorrhage. Most of these are due to aneurysms, spontaneous ones. The single most important cause of subarachnoid hemorrhage obviously is trauma, but the spontaneous ones are usually secondary to ruptured aneurysms. The other possibilities may be maybe AVMs. If you think somebody has got a subarachnoid hemorrhage, the idea is to image them as soon as possible. The longer you wait, the less is going to be the yield of the CT scan. And there is some data out there that suggests that if you are beyond 24 hours, your yield from a lumbar puncture is going to be much, much higher than your yield from a CT scan. I've still seen positive CT scans at 48 and 72 hours, but really depends on how much blood leaked out on the first one. If the first leak was catastrophic, then obviously you're going to see blood out several days out. But if the leak was small, then you may not see anything 12 or 24 hours later. So if you think somebody has got a subarachnoid hemorrhage, please get them scanned as soon as possible. CTs are better than MRs. Although you can pick subarachnoid hemorrhages out on MR, you need an expert interpreter, which may not always be available, and therefore CTs are much better. So this is another woman who has the worst headache of her life. She is a 24-year-old who had a PPH secondary to placenta accreta, was resuscitated, and post-resuscitation developed severe headache, which is not going away. This is her MR. So you've got a susceptibility weighted image here. You've got a T2, you've got a T1, and you've got a T2 sagittal. And the abnormality obviously is in the region of the pituitary. You can see that the pituitary is profoundly hypointense on T2. It is hyperintense on T1, and on susceptibility, it balloons out. Also, note that there are small areas of susceptibility dropouts in both occipital horns. So this is blood in the occipital horns. This is a woman who unfortunately has had a pituitary apoplexy. Most pituitary apoplexies occur in patients who are not pregnant. Sheehan syndrome, fortunately, has become very rare. with good obstetric care. Most patients who present with pituitary apoplexy are patients who have pituitary adenomas and then develop spontaneous hemorrhage into them. They look the same, except the size of the hemorrhage may be larger, depending on how large the pituitary adenoma initially was to begin with. So remember, pituitary apoplexy also presents with a thunderclap headache, worst of their life. If they've had headaches because of the pituitary adenoma, they may or may not have a chronic headache disorder-like picture. But if any time patient presents with an acute onset of severe headache and meningism, they need to be imaged. One thing which kind of simulates these these are not my images, these are from a published source. And this is a patient who has recurrent vasospasm or transient recurrent vasospasm. They may be extremely problematic to diagnose. They present with features that sound like subarachnoid hemorrhage. They may actually have small cortical subarachnoid hemorrhages, or they may have hemorrhages into the parenchyma. They sometimes have TIA-like episodes. They may have issues with diffusion restriction and press-like episodes. And sometimes, although not always, they do have these irregularities of vascular caliber, which kind of go away. So these are patients who present with features of thunderclap headache, recurrent thunderclap headaches, may have TIA-like episodes, but initial scanning may be negative, just something to bear in mind. To be honest, I've not ever discovered this on my own, but literature is full of these, and our neurologists keep asking us, could this be this? And when we have CT negative subarachnoid hemorrhages, to be honest, never diagnosed one myself. Okay, moving on. 71-year-old gentleman with who's a retired banker, has chronic renal failure, has diabetes and hypertension, headache for one day, on examination has a tense left hemiparesis, and this is his CT scan. This is a typical hypertensive subarachnoid interparenchymal hemorrhage centered on the basal ganglia with ventricular extension, early hydrocephalus, diffuse brain swelling. You may wish to do additional imaging after this, especially if they do not have history of hypertension. But in patients who have well-documented hypertension, there really is not much to do after this other than rehab. They may require decompression. That'll depend on further and on how they progress and what the comorbids are to begin with. So this is intracerebral hemorrhage. This is an interesting patient. She's a 30-year-old from Abu Dhabi, recent onset of headaches. They're worsening over time. There are no constitutional symptoms. And on examination, she is perfectly intact, no deficits at all. This is her MRI. And you can see that there are large subdural collections, which are predominantly hypointense on T2, but have areas of susceptibility dropout. This is a GRE image. And this lady has spontaneous subdurals. Now, spontaneous subdurals tend to occur more towards the extremes of age, so old patients and young people when they have lots of subarachnoid space, bridging veins which give way with minor trauma that the patient may not recall. But there are patients such as her who have subarachnoid, who have subdural hemorrhages, which may be recurrent, and hers is actually recurrent. She's had an angiogram which is negative, and she's currently being worked up for bilateral temporal artery embolization, middle meningeal artery embolization, because she gets these recurrent and she has no history of other features. So these are just some subdural collections on CT scan. The acute subdural, which is obviously hyperdense, looks like blood. The isodense when they start to get a little bit old. So do remember to look out for the isodense subdurals, and the chronic subdurals, which are hypodense and look and get close to the CSF density as patients, as the age of the hematoma progresses. This is another patient who presents with recurrent subdurals. Now, this is an interesting entity. These are patients who have, so let me just go through the features. So he has diffuse meningeal enhancement, which is non-nodular and is continuous, has got bilateral subdural collections, has got slit-like ventricles, has ballooning of the dural venous sinuses. You can see the ballooning of the superior sagittal sinus and the transverse sinus bilaterally, and has this typical sagging brainstem sign where everything looks to have descended. And this is a patient who has spontaneous intracranial hypotension. You don't always find a cause for this, but in this particular patient, we did find it. And what he has is a spontaneous CSF leak in his cervical spine. This is his cervical spine MR. We spend a lot of time looking for these. We don't always find them, but it's very rewarding if you do find it, because these patients can be helped with either a straightforward blood patch or a surgical procedure to fix the leak. So this, you can see, this is the dural sac. This is the CSF outside the dural sac. And this is the reason why. So he keeps leaking his CSF. And because he keeps leaking CSF, he his pressure keeps dropping and he gets these spontaneous subdurals. They have recurrent intractable headaches, which have the typical orthostatic feature to them. Moving on, 53-year-old gentleman, mid-level executive, family history of heart disease. He's mildly hyperlipidemic. He decided to get fit, went to a gym, extraneous exercise, first episode. Severe neck pain and headache, nausea, vomiting. And when he was brought into ED, so he starts with headache, rapid onset of loss of consciousness. And by the time he came to ED, he had fixed pupils. And the reason he had fixed pupils is because his CT scan looked like this. Remember so he has got an extensive posterior fossa infarction. Remember, infarctions per se are not painful. So people who have ischemic infarcts do not get headaches. People who leak blood into the ventricular system or the subarachnoid space do get headaches. If patients have headaches and then have ischemia, you really need to think about dissection. This patient we investigated, he had a left vertebral dissection. He did not survive. So this is a posterior fossa infarction. So anytime you have headache with an infarction, do think about arterial dissections because they will be painful. 27-year-old physician, recently married, doesn't want to start a family just yet. So goes on OCPs, progressive headaches for a week, severe headache today, associated with nausea, no focal exam, non-focal exam. This is a CT scan, and the initial diagnosis was normal. But if you look at it, it's not really normal. There is a high attenuation left transverse sinus. She has no hemorrhagic infarctions as yet. And she actually was lucky; she got away with it. But what she has is CVST, and we did the MR to prove it. So that's the MR. You can see loss of flow void on the T2. You have a big filling defect on the post-contrast T1, and the post-contrast MRV demonstrates the big filling defect. in the left transverse sinus. Remember, if you're going to do an MRV for CVST, you really need to do a contrast enhanced examination. Non-contrast examinations, if they are completely normal, are fine. If they are abnormal, you are never sure whether you're dealing with an artifact or you're dealing with something that is real. The artifacts on non-contrast time of flight or phase contrast MRVs are very high. So the standard of care really, if you're going to diagnose CVST, is to do a contrast enhanced MRV and not a non-contrast MRV, please. So this is a lady with CVST, 26-year-old school teacher. I'm just trying to go through these because I just wanted to show as many as I possibly can. We can take questions at the end if there are specific ones on here. She is on treatment for polycystic ovary syndrome for the past 6 years, has progressive headaches, which are worse in the morning, and she has onset of visual blurring. This is her MR. The ventricles aren't as slit-like as they are sometimes suggested, but they normally in this condition look like this. The dead giveaway is the dilated CSF space around the optic nerves, along with the flattening of the sclera at the optic nerve and the deep flattened pituitary with a deep recess over it. So this is a lady who has what used to be called benign intracranial hypertension. We stopped calling it benign because it is not. So this is idiopathic intracranial hypertension. They almost all of them have an underlying cause, and quite a lot of them will have a venous abnormality, and this is this lady's MRV, and you can see that this is a very abnormal looking left transverse sinus with a focal stenosis. So this is obviously a recanalized. So she had a CVST, which was probably subclinical, is left with venous stenosis, venous intracranial hypertension, venous hypertension, and has benign intracranial hypertension. So if you have a patient who has idiopathic intracranial hypertension, do go look for a venous anomaly, because that may be what that may be able to help them if you correct this. On the same note, the dural AV fistula, and again, you can see multiple dilated veins. You can see the absence of the flow void in the superior sagittal sinus. So this is somebody who had a superior sagittal sinus thrombosis and has developed an arteriovenous fistula. Secondary to that, these patients also have intracranial hypertension because of the venous component to it. They get stasis, and if you were to measure the intracranial pressure, they would be high. These need to have their veins opened up, or the fistula, ideally both fistula occluded and the vein opened up for them to get relief. 21-year-old gentleman, university student, non-responsive headache, nausea, vomiting, photophobia. This is a CT, this is his MRI. Very subtle features here. And the reason I put that in is to get you guys to ask your radiologists, if they're not already doing this, to start doing this. This is a pre and post contrast flare, same patient. Just look at the yield of the post contrast flare. So if you have a population like you do in Pakistan, where meningitis, both tuberculous and pyogenic, is very common, your radiologists should be doing this examination. That this is pre and post contrast flare. For surface enhancement, this is really the examination to do. And this guy has pyogenic meningitis. You can debate whether you should do a lumbar puncture on this guy, whether you're going to do, if you're going to, he needs a lumbar puncture, whether you should image him before or not is debatable. I would suggest that you do need to image him to make sure that he doesn't have signs of raised intracranial pressure. before you puncture, because you really do not want to stick needles into patients who have raised ICPs, especially if they have a shift in the intracranial structures. 43-year-old shopkeeper from the interior of Sindh, hypertensive, ischemic heart disease. He's been having hemoptysis for several weeks, has got progressive headaches and personality change, and presented with a seizure. This is his exam, CMR with contrast. You can see that there's a large cystic looking lesion with uniform enhancement. One thing which you would find very useful when you're trying to differentiate cystic tumors from abscesses is the diffusion weighted image. Remember, diffusion is not just for strokes, it's for a lot of other things as well. And if you have cysts that have diffusion restriction, the cysts are almost always abscesses. This guy turned out to have a tuberculous abscess. This was drained, he was treated. He unfortunately didn't do very well. But that's the nature of the disease, unfortunately. 18-year-old on acute myeloid leukemia, progressive headaches. And again, you will see a lot of this in Pakistan as well. This is a patient who has sinus disease. And if you go on the MR, you can see that this is profoundly hypointense on T2, enhances a little bit, diffuse enhancement of the skull base. So this is fungal sinusitis. This happened to be in a patient who was immune compromised. A lot of your patients who will present with this would be immune competent. And again, they present with headaches, facial pain, may have lower cranial nerve signs. MR and or CT is the way to go with them. Another banker has migraines, but the current headache is different. And he's been having hallucinations for the past 24 hours, very disturbed. A lot of psychiatric illness symptoms, and people actually thought that he was having an acute psychotic episode until they did his MRI, and he's got bitemporal signal abnormalities, and these are actually, his CSF was positive for herpes simplex, and he has herpes simplex encephalitis. And this is somebody with multifocal lesions. But anytime you have multifocal lesions, your differential is always between TB or infection versus tumors. Most of the time you would see them in Pakistan would be TB. This guy happened to have toxoplasmosis, but TB can look very similar as can metastases. This is somebody with a GBM. Intra-axial lesions with shaggy enhancement, central necrosis, but not a lot of surrounding edema. Surrounding edema is, in my opinion, an overrated sign. You really can't tell much about whether somebody has anything significant going on when they have, based simply on whether they have edema or not. So we'll just skip through this. I think we're just short of time, so we will. This is somebody with multiple metastases. Like I said, they can be very similar. And the tumors can be either intra-axial or extra-axial. The extra-axial meningioma or the acoustic are obviously things which you would want not to miss out on. Let me just move to, since we are coming to the end, we are almost there. Let me just go to this, which is important. So remember, if you have somebody that you think has an acute secondary headache syndrome, but the initial CT or the initial MR is negative, does not mean that they do not have a significant intracranial pathology going on. So subarachnoid, meningoencephalitis, CVST, all of these may have a normal imaging exam, and you need to be aware of these. You will either need to repeat the exam, repeat your exam, repeat your clinical exam, or get additional testing done so that you have, so that you can get a handle on this. So to conclude, headaches are incredibly common. Most do not come to the attention of physicians. You really need to do a physically, a good history and physical. Look out for your red flags. CT usually for acute, MR usually for chronic, but look at your patient and decide accordingly. And remember, normal imaging does not exclude serious illness. I think I've done my 45 minutes, so I will take questions now. I hope that was useful.
Thank you very much, Dr. Zafar Sajjad, for an excellent talk. Now, I think for the question answers, it would be easier if there are any questions to post it via chat, please. So you can send your queries through the chat box, please.
Okay. So where is my chat box now? Here. Okay.
Sir, there is a question coming up in the chat box that can someone please tell me how to differentiate between tension headache and blood pressure headache without the presence of a blood pressure apparatus?
This is beyond. I think ये वलियों और रसूलों की territory में जा रहे हैं. At least I don't. यहाँ जाते हुए मेरे तो पर जलते हैं. I don't know whether you could answer that or not.
Sir, I will have a think about it and then I can post it to the. Sir, there is another question: how to differentiate tuberculomas from toxoplasmosis and lymphoma on the imaging?
Okay, so that's a difficult one. So lymphoma is relatively easy. So lymphoma is going to be a solid one. Lymphoma is almost never cystic. And so it's a solid tumor that is diffusion restricted and enhancing, and that enhances uniformly unless you have treated it. So treatment naive lymphoma almost always enhances and has no necrosis. The problem may arise when you have toxoplasmosis versus TB. Sometimes you can't tell them apart. Toxoplasmosis tends not to have too much in the way of meningeal enhancement. TB tends to have a lot more meningeal involvement. Toxoplasmosis almost invariably occurs in patients who have immune compromise. TB can occur in both. But sometimes you really can't tell them apart. And sometimes you have to kind of keep the differential and base it on additional exams such as IGRA or CSF exam or the history or the chest x-ray or whatever else is happening.
Sir, there is a very good question: how to differentiate a DVST and hypoplastic vein?
So again, CVST, you should be able, in a CVST, even if it's thrombosed, you should still be able to see the entire sinus. The dural venous sinus should be filled with thrombus, but you should still be able to see its outline. So it's important not just to do the MRV, but also to do an MR where you have the anatomical structural images available to you. So that's important. The problem arises when you have a post-recanalization MRV where you have a sinus that has shrunk down or has fibrosed. Now, trying to figure out whether that is a congenitally small sinus or whether this is a post-CVST recanalized sinus may be problematic. And one of the things that you want to look at is especially look at the size of the jugular bulb. So if they have a CVST and a fibrosis, the jugular bulb would still be normal sized. That's a good indication to look out for. For congenitally small sinuses, the jugular bulb on that side would also be small. The other thing is that if it is very smooth, it is almost certainly congenital. If it's a little bit irregular and shaggy, it's almost invariably recanalization. Sometimes you cannot tell them apart. The more important question for me is large arachnoid granulations versus clots in the sinus. And they can be really problematic. And again, this is where your anatomical MRI would come in handy. So if what is in the sinus, the filling defect, is hyper intense on a T2 weighted image, you're dealing with an arachnoid granulation. If it is iso or hypo intense on a T2 weighted image, you're dealing with a thrombus.